Okay, so today we're going to be looking at the subjective examination in patellofemoral pain. For those of you that don't know me, my name is Claire Robertson. I'm a consultant physiotherapist solely specialising in patellofemoral pain. This is particularly useful for this presentation today because it really draws on that pattern recognition that I've generated from the last 10 years, and I'll be proposing to you some really useful, easily accessible and immediately possible to change your clinical practice from this presentation. So we have to first of all be clear about this. There's really no literature on this. So this presentation is based on the pattern recognition that I've seen from seeing thousands of these patients. So I would like to propose to you that patellofemoral pain is an umbrella term and question why is it that somebody who is, for example, an obese teenager that's hypermobile is going to have the same diagnostic label as an ultra distance runner. Clearly they might both have similar symptomology, but they're not going to be the same, and we need to utilise the subjective examination to signpost our objective examination, and we really need to try and think about elements of the subjective that will give us ways of prioritising, almost forming like a pecking order through which you can work in your objective examination. And we're really going to do this through clinical reasoning. So first of all, I ask all patients, do you have cinema sign? So in other words, do you have pain when you're sat still with your knee bent? Some people say no, others, yeah, a little bit. And then for other patients, this is their worst problem. So if this is their worst problem, we have to stop and think, what is it about this that we can glean information from? Well, they're sat still, so there are no issues around muscle firing and muscle strength. There's no issues around shock attenuation and foot biomechanics. So some of the things that we place a lot of importance on for patellofemoral pain should be sliding right down our pecking order, our priority list. Conversely, we need to think about considering muscle length, particularly quads length. So when they sit with their knee flexed, if the quads are tight, they're going to create a compressive vector through the patellofemoral joint. Furthermore, I would ask, does this alter if you cross your legs? If they say yes, it does, then this implicates the lateral structures such as the contractile proximal attachments onto the ITB. There's another subgroup we need to think about here, and that is those that have an edematous bulky fat pad. If that's the case, it can stop the patella gliding towards the foot during flexion, and a patella can end up having altered movement and sitting up quite high on the convexity of the trochlea with raised pressures. Now, most patellofemoral patients are fairly okay walking on the flats, but I ask, what do you like walking on hills? Now, a lot of them will not like walking downhill, but there is a subgroup that just particularly dislike walking uphill. And I would say to you, what is it about this subgroup that makes them stand out and gives you some big clues? And I think that they often have problems with calf length. If your calf is insufficiently long when you're walking uphill, it will drive you to either excessively pronate, which leads to a compensatory tibial rotation, which is undesirable, or it will put a greater demand on gluteal function, and if the glutes are weak, then it might lead to excessive and unwanted pelvic and or femoral movement. Footwear. This is very useful to ask. I ask this of every patient. Do you notice a difference in different shoes or when you're barefoot? If they say they don't like heels, don't make the presumption that it's the height that's the problem. Ask them if they notice the difference between a thin heel and a wedge, because if it's much worse than a thin heel, it might actually be the instability component that they don't like. And that gives you a clue that you need to look at their limb stability and aim to remove any unwanted movement. If they dislike things like Ugg boots, flip-flops or other shoes that provide very little hindfoot support, it's a clue that you might need to spend more time looking at their foot biomechanics. If they notice a difference, for example, in the week when they're in an office hard-soled shoe versus the weekend in a trainer, then it might be a shock attenuation issue. And this is particularly seen, I think, when we have patients with subchondral edema. If this is the case, bearing in mind a lot of home flooring these days are hard, it can be a very simple measure to recommend a home indoor trainer. So they come in, they get out of their shoes they've been wearing outside, but instead of being barefoot or slippers, they put on an indoor trainer so they get good shock absorbency inside as well. Now stairs, pretty much everyone with patellofemoral pain dislikes the stairs, but I would say ask one more question. Is it worse up or down? And they consistently will be able to tell you. The ones that have pain that's worse going up the stairs, we need to go back to thinking similarly to uphill walking. Think about gluteal control. Is it this extra demand is flagging up insufficient gluteal strength? Or is it actually that their quadriceps control, particularly in terminal extension, is poor and they're flicking into hyperextension in the last bit of the movement? This is particularly prevalent in patients who have a fat pad problem. If their pain is worse on descending the stairs, it's often patients that have worse joint surface pathology that have this. But also don't presume it's whilst they're loading through the joint heavily. It might be the last bit of the movement where their foot is still on the stair behind and their knee is maximally flexed. Then we're back to a similar scenario to the quadriceps length issue with cinema sign. Also, if they report a break, a point, a catch, an angle that they particularly hate working through, they might want to have a eccentric quads break at this point. This may signify osteochondral defect or chondral flap, and you need to have that in your mind. Now, squatting and kneeling. So we need to be a bit more clear than just saying those functional activities. Are we meaning into those movements, during the movement, or out of it? Squatting, are we meaning a gym squat, or are we meaning squatting down to the floor? They're very different demands. Kneeling, are they kneeling up, which is right onto the patella, or are they starting to get more pain as they kneel back through the tendon and fat pad, or actually is it when they're kneeling back on their haunches and their quadriceps are maximally stretched? That extra question will give you a lot more information. Pattern of pain. So I ask my patients, right, if you've got pain on the stairs and you get to the top of the stairs and you walk off, is it gone? Is it still there? And if they say, oh, it's gone again, then that's a very mechanical pain. Conversely, patients that report pain later on in the day, and particularly the next day or so, we have to be thinking that they're getting an inflammatory response. We have to be mindful of what structure is causing that and why. And then there's those that actually say that they improve with exercise. They go off for a run and during the run they feel better. For those patients, you need to query whether they've got patellar tendinopathy, or it might be that they have patellofemoral pain that's driven by muscle length issues, and as they warm up and things stretch a bit better, the pain subsides. Now, Crepitus, I've been fortunate enough to be awarded a research grant to look at the presence of patellofemoral crepitus and the meaning it has to patients. I looked at this in patients with a normal MRI and I did semi-structured interviews to try and really look at this issue in depth. I was really quite shocked at some of the comments that patients said, and here are some quotes from my data collection. It means my knee is wearing away. It means I have arthritis. My body's way of telling me to slow down. Now remember, these are patients who had a normal MRI. I even had one 26-year-old gentleman who was so perturbed by the noise in his knee. He said, I'm house hunting at the moment. I'm so upset about the noise in my knee. I'm worried about it. I've decided to only look at ground floor properties. That's really catastrophic, demonstrating gross fear avoidance. All patients also said they would not do an exercise given to them by a physio if it made their knee make their noise. So we need to be aware of that. We need to educate that crepitus is a normal phenomena and it signifies movement of fluid through a slightly irregular joint surface. Now this might be very superficial change in the top layer of the retropatellar cartilage that would be considered a normal finding in the adult population. The crepitus does not correlate with severity of pathology. And we need to make sure that people view the pain as the abnormality, and that is what we're aiming to get rid of, but the crepitus may remain post-removal of pain. Finally, quite a few patients have an infrapatellar fat pad problem, and it's useful in the subjective examination to have clues as to whether actually you're looking at a more fat pad problem. And I've drawn this chart to try and help differentiate. So the patellofemoral patients come in and they're often very vague about the location of their pain, whereas the fat pad patients will often point much more specifically to the fat pad. Patellofemoral patients don't like activities in flexion, so stairs, squats, getting out of a chair, whereas the patients with fat pad problems don't like positions near extension, like prolonged standing and walking. Hence the patellofemoral joint is a picture of worse in flexion, fat pad worse in extension. So the patellofemoral patient will often like to straighten out their knee to ease their pain, and the fat pad patient might actually stand with their knee in a bit of flexion. Fitting with that, the patient with patellofemoral pain dislikes heels, whereas the patient with fat pad pain will often choose a slight heel to relieve their pain. And finally, the patient with patellofemoral joint pain will rarely talk about swelling, but the fat pad patients will often mention to you that they've got swelling. So there's quite a few clues there that you can start to get a pattern. Oh, actually, this sounds more like a fat pad problem than a patellofemoral pain problem. And of course, don't forget that very often the two do coexist. So to conclude, what are the main messages from this short presentation? Well, don't just use the subjective examination to confirm your thoughts that it's patellofemoral pain. Take it a step further. Use it to actually give you some direction to break down this massive umbrella term. Get the patients to rank their worst task, for example, stairs, up or down, standing still or sitting still. It will give you an idea of their biggest problems, and it will help you create your pecking order in your mind for your objective examination. Also use the subjective examination to pick up on catastrophic belief systems, and also use it to help you suspect a fat pad problem. Thank you for listening today. I do hope that you found this helpful and will be useful for your clinical practice. If you would like to receive more education on the patellofemoral joint, then please enter your email at www.clairepatella.com. There are also blogs for patients and blogs for clinicians on related topics that I hope would be of interest to you. If you'd like a CPD certificate for this presentation, please email me. And if you've enjoyed this, then please do tell your friends. Thank you.